Hello everyone. Today in this lecture I am briefing about the procedure of cesarean section. So before you watch this video, I'll suggest you that you watch the previous video of cesarean section which I have made where I have discussed about the indications and the types of incision, that in which all condition we plan cesarean section, what all conditions are there and what all different type of incision are there. So that you can watch, and the link of that video is given in the description box below. So here in this lecture we'll discuss what all steps are there to incise the abdomen as well as the uterus. It means first we'll do laparotomy and then we'll do hysterotomy to open up both the cavities and deliver out the fetus and the placenta, and what all preoperative preparation we must do and what all post-operative precaution or care must be given. So first we'll see pre-operative preparation, what all things we kept ready and what all preparation we must do to prepare the woman for cesarean delivery. So firstly, as soon we planned cesarean delivery, first make the woman NBM, nil by mouth, and PO, nil per orally. It means she must not to be take anything orally, because if any gastric content left remain, then with the effect of anesthesia that can be aspirated. So to avoid that, she must be NBM at least for 6 to 8 hours prior to surgery, and she must be priorly informed or consent must be taken beforehand. So she must be aware of her diagnosis and the risk which could be happen to her or the baby. So she must be know about everything. So consent need to be taken beforehand, and certain medications need to be prescribed before surgery, like antacids could be administered, because what antacid does, it neutralizes the gastric content. So in case accidentally if gastric content is aspirated, then that can be damage the lungs. So to prevent that, we administer antacids, and along with that priorly antibiotic prophylaxis could be started. So prophylaxis means we need to take precaution beforehand once we incise the skin or give any incision, because this prophylactic or preventive measure prevent from any upcoming infection. Okay, so antibiotics like cefazolin intravenously could be administered, approximately 1 to 2 gram. It means cephalosporin or penicillin could be administered. These are beta-lactam antibiotics. Or in case if the woman is having allergies regarding these all, then clindamycin or gentamicin could be administered. Gentamicin is the aminoglycosides, so that could be administered if allergy is there. But in case, but in general, cefazolin intravenously is going to be administered. But keeping in mind that if the surgery is planned beforehand, it means if it is elective cesarean delivery, in such cases the antibiotics need to be given 60 minutes prior to the surgery. Otherwise, in emergency situation, we can administer as feasible as soon as it could be. Okay, then so why we are giving this antibiotics? Because we need to take precaution against any infection that could be happen later on because of this incision. So to prevent from infection, we are administering beforehand. The woman must be catheterized. So Foley's catheter can be introduced, can be kept placed, can be in the operative theater, that is OT, or it could be in ward. So we must monitor the urine output of women as well, to assess the bleeding status as well. Okay, so because if the more the bleeding is there, then urine output would be less. So to keeping in mind, Foley's catheter must be introduced. Then the IV line should be kept ready. It should be patent, because we need to continuously infuse IV fluids as the woman is NBM, and we need to balance all the hemodynamic status of the woman. So we can administer RL or 5% dextrose. So to administer the fluid, we kept IV line patent. Approximately 2 liters is to be infused. So along with that, there may be a chance of any blood transfusion as well. There may be a need if the woman land up in heavy bleeding. So to administer that also the IV line is needed, and along with that for the drug administration as well the IV line is needed. Next, the part preparation need to be done. So here the perineal area need not to be shaved, but rather nowadays the hair clipping could be done. So just trimming of the hair is enough. So clipping of the hair could be done, and the whole abdominal area as well as the perineal area needs to be painted with the antiseptic solutions like chlorhexidine we can use, as well as in case of that we can use povidone iodine solution. So any of the solution can be used for antiseptic lotion that to be painted over the abdomen and the perineum to prevent from any infection further. So this to be painted, and the position of the woman should be in slightly left lateral. In 15-degree left side, the woman should be lie in dorsal position on OT table, because in dorsal position with the gravid state, what happened, the whole weight can be on vena cava. Okay, so to avoid that compression, we are tilting just slightly left side. So we can place wedge underneath the right buttock, a triangular shape elevation, or we can modify this OT table to make the woman lie in slightly left direction, left lateral direction. So we can avoid that compression, so woman may not land up in hypotension as well. So to prevent from that, we will give this position. Blood tests need to be sent, very importantly, because we need to check out all the hemodynamic status of woman. So complete blood count need to be checked out. Basically we want the hemoglobin and platelet counts, and blood grouping and cross matching should be sent, because in case if heavy bleeding is there, then we need to transfuse blood. So we need to know the blood group of woman. Yes, and if cesarean section is planned beforehand, then fetal maturity to be assured primarily, because if there is no need to hurry, if it is planned manner, then the week of gestation must be assured first, and it should be, the procedure should be done after 38 to 39 week of gestation. Fetal heart sound must be checked. The rate of the fetal heart must be monitored first, and the neonatologist must be available, because all the documents related to the fetus is to be done by neonatologist. So the assessment, or if needed resuscitation, could be done by them. So they must be priorly informed, and the team of anesthesiologist must be available, because the whole surgery is going to be done under regional anesthesia or maybe under general anesthesia. It completely depends on the mother condition. So in regional anesthesia, spinal or epidural anesthesia could be given, where the half of the body below the chest is usually numb. The woman is not aware of what is going on, but she is awake in regional anesthesia. And in general anesthesia, she is not knowing anything, because she is completely unconscious under the control of these all drugs. Okay, so this decision could be taken by the anesthesiologist, what type of anesthesia is to be given. So the team of anesthesiologist must be priorly informed, and all the instruments, sponges and the needles should be counted well before surgery, during surgery and after surgery as well, to take safety measure regarding surgical procedure. Okay, surgical safety is utmost important. So these are certain preoperative preparation that we must do once we plan for surgery. Now what type of incision are there? That already I discussed in detail in the previous part, but just summarizing the few important things. If we want an emergent entry, or if we want the incision site to be large enough to better visualization, then in such condition the classical one is good. Classical incision, the incision which is that we are planning on the upper segment, but it is the rare one, not practicing nowadays or commonly, because the large scar is visible on the upper segment, on the abdomen. So cosmetically the lower segment is better because it is not visualized as in classical one. So the most common which nowadays we are preferring is the lower segment cesarean section. The lower segment is incising, and in lower segment also there are various other incision, like initially we can incise transversely, and if we want its extension then we can go with the upward extension in vertical manner, J-shaped manner, or it could be inverted T-shaped manner, means initially we are giving transverse and then medially we are incising. So it could be modified, but the most common one and the most practicing one is the lower segment transverse cesarean section, where the lower segment is identified in the uterus, which is passive, and transversely we are incising. And the most common incision, the pattern of incision which we are practicing nowadays is the Phalanx steel incision, which is giving on the abdominal wall. Okay, so that we'll discuss later. So first we'll discuss what all structures are usually cut in this laparotomy and the hysterotomy, because first we are incising the abdominal wall, and then once we get entry into the peritoneal cavity, then we'll incise the uterus. So firstly, the structure which we encounter during incisions are firstly the skin, then comes the subcutaneous tissues, then comes the anterior abdominal fascia, the anterior rectus sheet, the white glistening sheet, which is made up of aponeurosis of 3 muscle fiber, because the 3 muscle fibers which are running from laterally merging in middle and forming aponeurosis, they forming a sheet, rectus sheet, anterior rectus sheet you can say, or anterior abdominal fascia you can say. Okay, so this is made up of 3, that is the aponeurosis of external oblique muscle, and the merging fiber of internal oblique muscle, and the transverse abdominis muscle. So all the 3 aponeurosis muscles merging in center and forming anterior rectus sheet. So below the subcutaneous layer you encounter the anterior rectus sheet, a white glistening sheet. Now below to that is the rectus abdominis muscle. Okay, rectus abdominis muscles, and medially they are joining with the linea alba, and beneath rectus abdominis muscle is the attenuated fascia of transverse abdominis muscles. Okay, along with some fat and the lining of abdominal cavity, that is the parietal peritoneum is there. So beneath the rectus sheet is the transverse abdominis muscles, attenuated fascia, and the peritoneum. So these all forms the wall of anterior abdominal wall. So once these all lining incised, you enter into the abdominal cavity where you incise the uterus, that is the hysterotomy. So first in hysterotomy you encounter the outermost lining of the uterus, that is the visceral peritoneum. Then you meet the muscle fibers, the reddish shiny fibers. This is all made up of myometrium. Okay, so myometrium you encounter, and then the decidual lining, and finally the amniotic membrane which encloses the cavity and where your fetus is lying inside the cavity. Okay, so these all are the lining which you incise in the hysterotomy. Okay, so these are the structure which are being cut in this cesarean delivery. Now how it is to be performed? So firstly, the technique through which the abdominal incision is to be given 3 cm above the superior border of symphysis pubis. Okay, so the technique where you are incising the abdomen in transverse manner is called modified Phalanx steel incision. Okay, so here in this incision you are using scalpel to cut where you are cutting or incising just above the 3 cm from the superior border of symphysis pubis, or you can say at the level of hairline of pubis. Okay, hairline of pubis is the landmark where you are incising. So with the help of scalpel, you are incising the skin and underneath the subcutaneous tissues. You can use scissors as well as or the scalpel, or even though you can use your fingers, the index fingers, to keep them down and extend laterally. Now after that, you encounter the fascia, that is the anterior rectus sheath that I already discussed, from which it is made up of. So this lining is also to be cut transversely. Okay, you will give the incision over the transverse manner. So keeping in mind that once you cut this line, the anterior rectus sheath, just beneath this lining are the various neurovascular structures. If they damage or if they disturb, then various sensory loss as well as the blood loss could be happened. So the structure that usually lies beneath this rectus sheath are in the nerve fiber is the ilioinguinal nerve and the iliohypogastric nerve. That could be disturbed, but in general they are not disturbing. If you are giving incision too laterally, if you are extending too laterally, then only these all disturbs. Otherwise they will not disturb. So if these two laterally incision is to be given, then they can be damaged. And the vessel that lies underneath this rectus sheath is the inferior epigastric vessel. That could be damaged if the incision is too lateral. Otherwise in general condition it is not disturbing. Okay, so keeping in mind how long incision to be extended to not to disturb these all neurovascular structures. Okay, so subcutaneous tissues, underneath that is the anterior rectus sheath, that to be incised in a transverse manner. Now after incising in a transverse manner, what you will see? The rectus abdominis muscle. Now in this Fannin steel incision, you are not going to cut this rectus muscles. You are just separating or spreading or letting them to move laterally, rectus muscles, because under the effect of anesthesia the muscles are too lax. These are relaxed, they can easily separable. So you can just move these rectus muscles laterally, and medially you encounter one connective tissue, that is linea alba, that you can cut. Okay, so after removing these all aponeurotic muscle fibers side away or cutting them, incising them, you encounter the next layer, that is the attenuated fascia of transverse abdominis muscle and the peritoneum, the parietal peritoneum. So you need to pick up at the top by the use of forceps, because you can't give this in a sharp manner, because there may be any other structure that lies underneath can be lacerated. So you need to pick up the structure, the peritoneum, with the help of forceps on the top, and by using the forceps you are holding this peritoneum and incising from top to bottom in a vertical manner. Okay, so once you incise, even though you can spread by the use of fingers as well. Okay, so once you incise this peritoneal lining, now you enter into the peritoneal cavity or the abdominal cavity. So all the layers of anterior abdominal wall are now being cut. Okay, so your laparotomy is to be already done. So here in each and every step, keeping in mind that if the heavy bleeding vessels are there, if you encounter and the bleeding is too heavy that obstruct your visualization, then time to time coagulation, or you can say cauterization and ligation need to be done whenever it is required for better visualization. Now you reach to the uterus. So after giving this incision, you can now visualize the uterus. So here in the uterus, the outermost lining is the visceral peritoneum. Okay, and we know there is a reflection of visceral peritoneum because in front of the uterus there is a bladder. So the visceral peritoneum reflect over the bladder and form a UV fold, utrovesical fold, that we already know in anatomy. So this is the landmark where we need to cut or give the incision over the uterus. The hysterotomy is next to be done. So So UV fold is the landmark where we need to incise, because there is the lower segment. Because if you are directly giving incision over the above part, then that you are giving incision over the upper segment. Okay, so here in this we need to identify the part. So UV fold is the landmark. So you need to pick up the UV fold by the forceps and give incision laterally with the help of scalpel. Okay, so when you are giving the incision and holding the forceps, you can easily feel the part, that is the bladder. So once you cut the visceral peritoneum, with the help of index finger you can push down the bladder. So you may not be accidentally injure the bladder when you are incising the layers. Okay, so with the help of finger you are pushing the bladder down, and with the help of scalpel in a transverse manner only, you give incision over the myometrium layer by layer, because here the lower segment is too thin. Yes, because it is well formed. Upper segment is comparatively thicker, but lower one is thin. So you give strokes in a very easy manner, layer to layer, not too deep, approximately 1 to 2 centimeter. So once you give this incision laterally in a transverse manner, or even though you can, once you incise, you can put both the index finger and extend laterally, transversely in upward direction in a curvy linear manner. Okay, so you can extend this incision, and it is not to be that much large that it can involve uterine vessels. So remember the anatomy, laterally there are the uterine vessels, so it can be damaged. So it could be large enough to deliver out the fetus, but not to be large to disturb the vessels. Okay, now after giving this incision you will encounter the fetus, because there may be a chance that the amniotic lining could not be ruptured. Then in such condition you can give Kocher forceps, use that and rupture the membrane, but most of the time the membrane usually ruptures, and the fluid, the amniotic fluid as well as the bleeding, this all comes out on the surgical field area. So continuously you need to suction all these things to clear out and visualize better. So once the fetal head is visible, when you are putting your hand just beneath the head, you can grasp with both the hand, and as the woman is in anesthesia, so she cannot apply further pressure. So with the help of other assistants, you can give fundal pressure, and by this you can pull the head over the incision in downward and upward manner, remove both the shoulder, anterior then posterior, and finally the trunk is removed. So by this manner you can deliver out the fetus, and as soon the fetus is delivered out, clean all the mucus which lies inside the oral cavity and the nasal cavity, wipe the baby properly, clamp the cord, cut in between, and hand over the baby to the neonatologist for further assessment. Now as soon the baby is received by the neonatologist, what you need to do next, here the placenta is there, that need to be removed. So it doesn't mean that the uterus is open up, so you just pull the placenta or manually remove the placenta. It not to be practiced, rather we need to do active management of third stage of labor. It means we need to administer oxytocin to deliver out the placenta by its own. So oxytocin is to be administered, and with the other hand you can give massage the fundus, and with the other hand you can pull the cord to deliver out the placenta. It means controlled cord traction you are giving, and as soon the placenta is delivered out, check for its completeness. It means the cotyledon, the fetal membrane. Okay, so as you confirms that nothing is left behind, all membranes, cotyledons comes out, then explore the uterus using your hand, remove all the clots and blood, suck all the fluid and the blood which lies over the surgical area, clean this all area, and then start repairing. Okay, so for repairing chromic catgut, it means the absorbable suture material is used, and the first layer which is usually suture up is the myometrium. So keeping in mind that both the angle both the angle of transverse incision needs to be in the stitches, no area to be left behind for further oozing of blood. So keeping the angles in the stitches, give continuous suturing in a single, or someone prefer two stitches to close this whole uterus. And even though someone prefer keeping the uterus inside the peritoneal cavity and then stitches, and some prefer the uterus to be keeps out over the incision, placing over the abdominal wall, draped abdominal wall, and then they suture for better visualization. So either of the technique is good enough, and it is for their convenient. So the innermost lining is to be sutured up. Then once it is to be sutured up, all the uterine adnexia, it means the fallopian tube, ovaries, these all need to be examined, because you are opening the whole abdominal cavity. So all adnexia should be examined properly for proper documentation. So as soon the myometrium lining is closed, it means the uterine incision is closed, then keep the uterus in its place, explore whole thing. Then finally, for closing the abdominal wall, keeping in mind that we need not to stitch the peritoneal lining, the visceral and parietal, they both remain open, okay? Because in surgery it is practiced that more the suture you are using, that is more the foreign materials you are using, more chance of infection will be there. So to avoid that, there need not to be stitched each and every layer. So peritoneal lining left remain open, and the next lining, that is the rectus abdominis muscles that goes laterally, they come closure once you stitch up, okay? So there need not to be stitched the rectus abdominis muscle, because we didn't given any incision over there. So the muscles that goes laterally, that comes closure once you stitch up. And the layer which comes over the rectus abdominis muscle is the anterior rectus sheath. So this lining is to be identified properly, the counter, the superior and the inferior edges, and it is also to be closed down with a continuous manner in a single stitch, okay, including the edges of the incision, okay. And over this anterior rectus sheath is the subcutaneous tissue, and that layer is also not to be closed, there is no need. And the final layer which is to be closed down is the skin, okay. So with the help of these all forceps, keeping both the edges closure, and with the use of continuous or interrupted suturing, you can use subcuticular stitches or metal staples. So whatever adhesive glues, whatever the surgeon practices, either of the technique is good enough. So last layer which is closed up or closed down is the skin, okay. So after closing the skin, again we need to paint the incision line with the antiseptic lotion to prevent further infection, and keep one dressing over there. Now what all post-operative care you must be done? So as soon the regional anesthesia fade, or as the general anesthesia is also fade and woman is partially awakened, in OT table itself you need to check out the vitals as well as the urine output, the bleeding status, the uterine tone. So we have a correct idea about the tonicity of the uterus and all this thing. So once the woman is stabilized, you ensure that the woman is now stable, then you can shift the woman to the post-operative ward, and there these all things need to be checked in every 4 hourly, because sometimes the urine output would be less, and this could be because of the unnoticed bleeding or any antidiuretic effect of the oxytocin. So keeping in mind all this thing, urine output must be recorded, and the woman is encouraged to breastfeed her baby, okay, and it could be done on the same day of surgery, once she is fully awake from the anesthetic effect, and she is encouraged to ambulate on the same day or the next day onwards. She can move her legs, and she can take deep breaths, or she can sit on bed or walk with assistance, because it is noticed that the venous thromboembolism, the formation of clot in vessels, are more in cesarean delivery as compared to vaginal delivery. So to avoid that, the woman must be ambulate and she moves. Okay, so because with this ambulation, whatever she gains, the extra cellular volume, physiological volume during pregnancy, that is to be removed, or that is to be excreted out with this ambulation only, and the clot would be not formed with the ambulation. So she must be encouraged for that. The catheterized bladder must be removed. It means the Foley's catheter must be removed after 12 hours, because she can be ambulated and she can go and pass the urine. And for the diet, she can take liquid diet on the same day as much she can tolerate, and the next day onwards she can take semi-solid or light food for digestion. Okay, because heavy diet can't be easily digested and she may feel uncomfortable because she is not able to move as much as in normal vaginal delivery. And the stitches are also to be evaluated for any bleeding vessels or any wound hematoma. So on third day the dressing could be changed, and on day 4th, if the metal staples are used, then these all could be removed. But if subcuticular stitches are used, then these are absorbable, they need not to be removed, and time to time dressing could be done so that the incision site could be easily visualized and evaluated for further any infection. And along with that, analgesics could be administered to relieve post-operative pain. Okay, and by the day of 4th, in non-complicated or uncomplicated cesarean delivery, she can be discharged. Okay, and very important, first 1 or 2 weeks her activities should be limited to self-care and for the baby's care with assistance only. Okay, she need not to do any other heavy works or any routine works for at least 1 or 2 weeks. So these are the basic post-operative care that should be keep in mind. So here in this lecture we have discussed what is the cesarean delivery and how this procedure is to be performed, what all preoperative preparation we must do, and what all post-operative care we must keep in mind. Thank you.